Okay, so today I am here with Nicole Coleman, PT Fabuloso. Nicole is board certified in pelvic health, and we're going to talk about the purpose of this conversation today is to introduce you guys into how pelvic health fits into the physical therapy profession. Then we're going to talk about how, if you have an interest in that, how you can start as a clinician into pelvic health. And then we're going to talk about how it is not just a specific issue to a specific population, how pelvic health affects orthopedic issues and the population in general. So, Hi, Nicole.
Hi, Farley. Thank you for having me. I'm excited to talk about this today and to the students.
Yeah, so kind of give us a little bit of background about you and your career.
I graduated from PT school in 2010, and while I was in PT school, I live in Michigan, I became interested in pelvic floor, pelvic health, women's health, and while I was still in PT school, I became known as that women's health girl. You know, people knew that I was interested in it, and it made almost everyone uncomfortable to talk about. And for some reason, I have a God-given gift to be able to talk about these things uh, with a degree of comfort. And, you know, it's quite possibly because as a child, I struggled with constipation and bedwetting. So I had to become very comfortable with talking about bodily functions at a young age to doctors and health providers and my parents. And, you know, I went through different ways of trying to treat it. And along my own journey, figured out some things as well. And so I was interested in pelvic health for personal reasons, but then also realizing that pelvic health issues affected so many people, I just became naturally drawn to it. So as soon as I graduated from PT school, I started pursuing advanced education through the Herman and Wallace Pelvic Rehabilitation Institute, taking their pelvic floor courses, and completed the 4-course series. I think now they've congregated it into 3 courses, and I completed that within the first 3 years of graduating. And within 6 months of graduating, I began treating pelvic floor dysfunction. And in 2017, I became board certified. For the previous 3 years, I had been working solely in pelvic floor dysfunction, but at an orthopedic spine clinic. And I noticed that and even early on in my career, how much overlap there was with pelvic floor dysfunction and orthopedic issues, neurological issues, geriatric issues. And so throughout my entire career, I've been trying to sort of bring together the idea that pelvic health isn't a separate thing that, you know, we only talk about behind closed doors and only treat with our pants off. You know, that it needs to be brought into the conversation with all of our patients because there is a very high correlation between back pain and urinary incontinence, and back pain and pelvic pain, and hip issues and pelvic floor dysfunction, and breathing issues and mobility issues. So really, I wanted to spread the word that pelvic health is something that all of us should, you know, at least be aware of. And, you know, be willing to accept that that might be part of the problem. And if we're not willing or able to discuss and treat it ourselves, then be able to refer it on at least, so that the patient is getting that comprehensive approach and treatment. Because if we just address one issue without addressing the other, that issue that we are treating might not ever get better because of how the body is connected and moves with all of these pieces connected. So that's how I sort of began my career and how it evolved to where I am today.
Okay. I think I think you really touched on a point that I want to bring up as we continue in this conversation, because even throughout this, the referral process is important. That, as a student, you still got to learn about this, and it may not be your cup of tea. It is, but it's not any different than neuro may not be your cup of tea. You may be more orthopedically minded or more pediatrically minded, and that's a great thing about our profession. But you've got to have a working knowledge of it and when to refer or suggest or even educate. So it's not a female specific issue.
No.
And it's not just a down there issue. It's not just a below the belt issue at all. So I think that's super important to have an open mind as we're going through this conversation today. And just like here at school, we're exposed to other things, to hippotherapy. That may be something that never interests you at all, but knowing the workings of different things and when to refer or suggest or educate is an important part of what we do as professionals.
Absolutely. Absolutely.
So Nicole, talk to us a little bit about pelvic health in physical therapy. What conditions are you talking about treating? What is this mysterious thing called the pelvic floor? And kind of give us a little bit of an overview and introduction to that as a whole.
Okay. When we talk about pelvic floor dysfunction specifically, we're referring to all ages, men, women, and transgender people, is urinary function and dysfunction, bowel function and dysfunction, and sexual function and dysfunction. And then pain in the region of the pelvis and sort of that saddle region in between the pubic bone and the coccyx. And but that's, sorry, Lucy, she's been all over. I'm sorry about my dog. Come here.
Oh, no
okay.
worries.
It's the pelvic floor is a group of muscles that connect from the pubic bone to the tailbone, and they help keep urine in and eliminate urine, keep bowel in and eliminate bowel, and then also are involved in the sexual reproductive process from both a male and a female perspective. So those muscles are involved in a lot of functions and need to be able to have they sit below and support a lot of things, and they need to be able to sit at a good resting length so that they're not too tight or too lax to support, and then they need to be able to contract to hold things in and relax to let things out or to let things in terms of sexual activity, if you're talking about penetration. So these muscles need to be able to do a lot of things. And if they can't coordinate, then that's when we get involved with dysfunction, whether it's loss of urine with urinary incontinence or urinary urgency or frequency, or the inability to empty our bladder all the way, or constipation, or the incontinence of feces, or just not being able to eliminate well and not being able to wipe well, get a good clean wipe when we eliminate our bowels. And then be able to participate in sexual function to the degree that we want, be able to participate in sexual activity, penetration to whatever degree, orgasm, things like that they're involved with. And then when they're not working, they can also become too tight and cause pain in that area. So those are specific to pelvic floor dysfunction, and the types of diagnoses we discuss and treat with patients when we're treating pelvic floor dysfunction. Was there a second part to your question?
No, I don't think so. I was just sitting there going through all of that, and I think that's a great overview about that. And so if I'm sitting here as a student going, oh my gosh, I'm never going to be comfortable to talk about that, and what therapists actually treat that, what is going on? That is not why I got into PT. talk a little bit about just some general things about how we treat um, for the pelvic floor and different things like that. Because as you and I have talked about on different conversations, since this is not our first rodeo having conversations about pelvic health, I want to make sure and ensure to the students that that they are comfortable with a working knowledge of what's going on, even if this is not their jam.
Okay, so a pelvic health therapist will get a good history on what their particular symptoms are and the other systems involved. So if they come to you for something like they're leaking urine, stress incontinence with cough, sneeze, laugh, jump, lift, carry, something like that, we're also going to talk to them about how they're able to empty their bladder, if they have urgency, frequency, if they are able to eliminate their bowels appropriately, or whether they leak feces. And then we'll ask them about their sexual history, to the degree that if they are sexually active, did they have issues with it? Or are they not sexually active because of issues, and would they like to be? So we get a good history, a comprehensive history of the pelvic floor function and dysfunction to start. Then we also talk to them about any other orthopedic issues they may have. Do they have back pain? Do they have hip dysfunction? And then we go, up and down the chain from there to talk about what else they may have going on neurologically, orthopedically, because, I don't want to forget neurologically, because we also work with people who have neurological dysfunction and also have some associated pelvic floor dysfunction. Perhaps someone is in a wheelchair and they are a quadriplegic or a paraplegic. There are some things we can do to address bladder and bowel and sexual function with them. So we talk about all their other systems as well to get a comprehensive history. And then if the patient consents, we do an internal examination. Now, in a female, ideally, that's the external pelvic floor and genitalia, because there are muscles there to assess whether they have pain or discomfort, as well as internally in the vaginal area, and a rectal examination, because there are muscles that are involved in functioning in different areas that you can feel through an internal examination that you cannot feel through an external examination. And you assess if there's tension, pain, how well those muscles can contract, the strength to which they can contract around your finger and then relax. And also, if they push, do those muscles lengthen? We talked about needing to be able to lengthen. And of course, if there's any pain along the way. And this is not done to the degree that causes increased pain, or I've had patients who have went to therapists who weren't qualified and they ended up having bleeding afterwards. So a qualified physical therapist will do that to the degree that the patient is comfortable with and able to tolerate without increasing pain, symptoms, or causing tissue damage. And so it depends on the patient's status and comfort level and your training as to how far internally you would go. And in a male, you would assess the genitalia around the scrotum and the base of the penis. And if they, consent and are able to tolerate an internal rectal exam. And you assess the same things in a male in terms of how those muscles are functioning. Does it cause pain? Are those muscles able to contract and hold? Are they able to release on command? Can they lengthen to a certain degree? And does any of that cause pain? So that process involves a good history of, their pelvic floor, as well as other aspects of their bodily functions, their emotions surrounding it, what their goals are, an examination, and then your treatment follows as to what you find. The diagnosis sometimes can be an indicator of what's going on, but it's not black and white. If they have stress urinary incontinence, it doesn't necessarily mean that their muscles are not strong enough. It could be that their muscles are tight and therefore they're leaking urine because they are already tight and they can't tighten to keep urine in when they have forces pushing down. So your diagnosis that they're coming in with, their symptomatic diagnosis, doesn't always necessarily correlate with your physical therapy diagnosis and how you treat them, but sometimes it does. And so you need that thorough examination so that you get the appropriate physical therapy diagnosis, so then the appropriate treatment follows. And it usually, anywhere between 6 to 12 visits is a typical episode of care for a diagnosis such as this.
So within that episode of care, what does treatment kind of look like, and what is the role, how do PTAs play a role in treatment?
So based on what you find during your examination is what dictates your treatment. And I had patients that were not comfortable with internal examination, and I would assess externally how those muscles felt over their pants. I still had to feel the area to find out if those muscles were tight or not working well and not contracting well. And so in the example that they do have, let's say, stress urinary incontinence, because that's a very, very common diagnosis, that's the unintentional loss of urine with activity that increases pressure through the abdomen and pushes down, and the pelvic floor muscles aren't able to contract well enough to keep urine inside the body. Even after someone has emptied their bladder, we still have a little bit of urine in there, so they can leak even if they feel their bladder's empty. So say you find that their muscles cannot contract and hold well, you would do something called pelvic floor muscle training, which is teach them how to, this is where the word Kegel comes in, that is so popular across so many threads, but is only indicated, gosh, I don't know, maybe 40% of the time with pelvic floor dysfunction, is teaching them to be able to do a Kegel at an appropriate strength and hold it so that you can build that muscle contraction, strength, force, and ability to hold, and then relax. So you teach them to be able to appropriately do a Kegel for endurance, working up to 10 seconds, and then 10 seconds of releasing. And you typically will do up to 10 of those, up to 3 times a day, depending on how they respond. And also the quick contractions, because your pelvic floor muscles contain, I didn't mention this, they contain slow twitch muscle fibers and fast twitch muscle fibers. So you need to train. Gosh, I'm sorry. I'm getting a package. These are the hazards of working from home, right?
Yes. Well, especially as we're recording this, this is normal for what
it is.
has happened this whole year.
It is. You can probably hear my dog, even when she's not barking. Okay, that's good. Thank you. Come here. I don't have young children. I just have a super annoying puppy. She's cute though. She wants attention now. See, you did a good job. Now be quiet.
To see.
So the pelvic floor contains slow twitch muscle fibers and fast twitch muscle fibers. So they need to be trained both in endurance and strength, and that quick contract and relax. So then you also do quick flicks where you contract, relax, contract, relax, contract, relax. And throughout time, you build muscle hypertrophy, muscle strength and force and endurance, as well as that ability to turn on and off. And then you incorporate that into functional activities so that those muscles incorporate with the rest of the body to be able to turn on when you need it, such as a cough, a sneeze, a laugh, a jump, a lift, a carry, something like that. And some people leak urine just when they go to stand up. So something simple as going from a sit to a stand, some people need to be trained with those muscles with the rest of their body to be able to decrease and then eliminate. And many people, you can eliminate stress urinary incontinence through pelvic floor muscle training. So that's the example of weakened or lengthened muscles in the pelvic floor. When it comes to muscles that are shortened and tight and usually causing pain, they need to go through some stretching that we usually use something called a dilator, and they're very small, and you can stretch the muscles through the vagina or the rectum over time, and then you can increase the size of the dilators to help lengthen those muscles over time. And teaching people, and we have something called biofeedback that we often use in pelvic floor, which you can use an internal sensor through the rectum or the vagina, or you can use external sensors around the opening of the rectum, and get real-time feedback about the electromyography, the electrical activity going on in the muscles, that shows up on the screen that correlates with a picture, whether it's a flower that closes and opens or a dolphin that jumps. And they can retrain their muscles that way. And if they need to relax and lengthen, you teach them over time to allow those muscles to relax, as well as lengthen them with dilator treatment. And that's typically if someone, common symptomatic diagnoses, maybe stress, or not stress, urinary urgency or frequency, constipation, pain in anywhere in the pelvic floor region, and pain with sex, whether you're male or female. No matter what type of activity, because you can have pelvic pain with just even arousal. That's something that I've seen even in young men. So we train those muscles to relax over time, but not too much, because then we still want them to be able to keep things inside. So it's not an aggressive stretching program. Now, there's other behavioral things, dietary things that go along with that you learn throughout the course of your training. And then you also address area around, specifically around that pelvic core region of the pelvis, the hip, the abdomen, the low back. You work on those areas as well, which we can talk about a little bit later, of the pelvic core and how that relates to other dysfunctional areas of the body. Those also need to be addressed. And how does the PTA fit into this? So for the typical route, if someone wants to, like, yes, this is what I want to treat, you are able to, as a PTA, to go to continuing education courses to learn how to do these types of assessments and treatments. And under the direct supervision of a physical therapist, you are able to, and it depends on your practice act in your state, but in most states you're able to do, internal treatment. The physical therapist will do the evaluation, the diagnosis, set up the episode of care, the plan of care, and physical therapy assistants are able to implement the plan of care and work with the physical therapist, the licensed physical therapist, as the treatment goes on, if adjustments need to be made based on how that patient responds. So there are physical therapy assistants who work in this area under a licensed physical therapist, and they make a career out of being a pelvic floor therapist. For people who are like not so interested, there are other ways to approach it, in just being aware that these things exist. The correlation of back pain and stress incontinence is anywhere from 72 to 87%. I've even seen studies that said it can be as high as 94%. So being aware that if you are seeing someone who has low back pain, in both men and women, there is a high likelihood that they're also experiencing stress urinary incontinence. If they're having any type of pain, there is a high degree of likelihood that it's affecting their ability to get to the toilet in time to eliminate their bowels or their bladder. And it's also affecting their sex life in some way, if they are having sex or if they would like to be having sex. Because mobility, we need to be able to move, to get to the bathroom, to sit on the toilet, to eliminate, to wipe, to do things, to adjust our clothing. To be able to have sex, we need to be able to move in different positions and use a lot of muscles in our body. So if someone isn't as interested, I think it's in pursuing pelvic floor as a type of like a career path. I think it is really important to know that there's a high correlation between pelvic floor dysfunction or some aspect of their life regarding poop, pee, and sex, that's kind of what we talk about as poop, pee, and sex, is being impacted, and being aware that it might exist. And, I encourage people to ask, especially clinicians, physical therapists, physical therapy assistants in our field, to be willing to ask a couple of questions about that in their own comfortable language. Has your sex life been impacted in any way? And if they don't want to talk about it, that's fine. But sometimes they need that invitation to talk about it. I'm sometimes reluctant to share this story, but I think it's a good way to open people's eyes. I've been treated by physical therapists myself for back pain, neck pain, even pelvic floor dysfunction. And I once was being treated for neck issues, and it was getting better. But there were aspects of my intimate life that I couldn't engage in that I wanted to, that we hadn't talked about. And it was a friend of mine who was treating me, and she was getting ready to discharge me and say, okay, look, your range of motion looks okay. I think we can discharge you. And my personal goals hadn't been met. And I had trouble bringing it up, as comfortable as I am with talking about these things. And there was some aspect of, my comprehensive plan of care that we hadn't addressed because neither of us brought it up. And I was a little concerned that I would never get better with a certain aspect of my sex life. And, eventually I kind of told her on the side, and we made sure that I had the mobility I needed for some things. And it did get better, but she was about to discharge me without us discussing my goals, my personal goals that I had trouble bringing up as a board certified physical therapist in women and men's pelvic health. So I imagine that there are people who are struggling with some aspects that are not going to breach the subject themselves. And it doesn't mean that you have to, dive in, so to speak, as much as be aware that there might be something that you can address without going below the belt that might help them feel more comfortable, or make modifications, or even just to assure them that as things continue to get better, other things will also improve in regarding their pain and mobility. So I think it's important for us to be aware that some aspect of their life, if they're coming to see you, when it comes to poop, pee, and sex, and I don't have a more smooth way to say that other than it's some aspect of one of those three things has most likely been affected directly or indirectly. And they might be looking for someone to reassure them or help them. And it may be that you find out that they're struggling with something else and you refer them on. That might be the degree to which, if we did that, there are people out there who want to help people in those aspects. So if it's not your calling, you don't feel like you have to force yourself, but you might be the person who helps identify the need to get them to the person they need in order to get the treatment they need. And, their primary care physician might not bring it up. Their, orthopedic doctor. So it's important to know that that might be happening. And at least to the level, if you give them an opening and they bring it up to you, you can be that resource they need to get the treatment that they want and need. And if they don't want it and you think they need it, you can just let them know there's treatment out there. And if they ever want it, give them the website to the section on women's health of the American Physical Therapy Association and move on. But you might make a difference that no one else is willing to even talk about if you're willing just to talk a little bit about it. And physical therapy assistants can do that as well.
Yes. And that was the point I was going to make. And we've talked about that in other classes and different things. And it's not specific to, that's a good story to drive that point home. And it's not specific to what we're talking about today in pelvic health. It can be across anything, because it may even be that depending upon how things are set up, we've talked about this before, the PTA may be spending more time with the patient than the PT. So they're going to know more things and are totally within their practice guidelines, practicing at the top of their license to help educate and to go back to the PT and say, hey, I learned this. Or just be that person to show that information. In healthcare, we talk about this a lot, and this has come up through all the things going on in the pandemic and vaccines and stuff, is giving people information in a comfortable, non-judgmental way, educating them, and then allowing them to make decisions. Because this is still, pelvic health is still the best kept secret of healthcare and physical therapy, and super important.
Yes.
And we're missing the boat on so many things about that. But that is perfectly within a PTA being able to be that resource and be that advocate. Because we talk a lot about advocacy, and the unique position and unique corner of the healthcare system that we hold, and how much time we get to spend with our patients.
Oh, that's why I became a physical therapist. I was trying to decide how to pursue my career in healthcare while I was in my undergraduate studies. I was trying to decide between going to medical school, going to nursing school, going to PT school, going to chiropractic school, becoming a psychologist. I explored all of those options, and I chose physical therapy because we get to spend the most time with our patients, to have the ability to impact their lives in a positive way more than their primary care physician, their orthopedic doctor. Their massage therapist might be another person that spends as much time, but they don't talk as much as provide passive treatment, which can be beneficial, but we engage with them even more. And that's absolutely why I became a physical therapist, is that as physical therapists, physical therapy assistants in this profession, we spend the most time one-on-one with our patients and have the ability to develop relationships that they trust us, that they can share information with, and that we can provide them with avenues, whether we provide the treatment or a referral. We are in a very unique position to do that. And it's, in many ways, one can argue that it's our, like you're talking about, advocacy is our professional responsibility to be an open ear and occasionally ask a question that maybe we don't think they want to talk about, but they might want to. And more often than not, they're going to be appreciative that someone's willing to talk about something that no one else is, at least in their perception, if we're reaching the subject.
Oh yeah, because that's huge with that story you told a little bit ago. You are a professional, and you were uncomfortable, and you wanted this addressed, and you were even, you do this, you went to the other side of the treatment, and we're having issues with getting that addressed, and you're a therapist. So for somebody who has no medical training, no scientific background, they don't know what they don't know. So we've got to be able to be comfortable in opening the door sometimes. And I think also, if pelvic health is one of the most kept secrets of physical therapy, how the pelvic floor affects core strength, core function, all the things there,
Yes.
is an even tighter kept secret. And I know for me, no pun intended, as we talk about things, for me, and it was probably midway through, it was probably about 6 or 7 years ago, where I started, because I've always been on the fringes of pelvic health with different places that I've worked and different things, and been a huge advocate for it, even though I didn't pursue that in my career. And it was probably about 6 years ago where I really started incorporating some pelvic floor treatment in a number of orthopedic dysfunctions, and had a huge change in results. From something so basic, from a sit to stand, going from, I've had patients go from standby assist or min assist with a sit to stand to completely independent when we engaged the pelvic floor, that they were able to stand up off the table. once I taught them that, and I mean, just bounced right up. And so that was a huge eye opener. And we were not ever even working on that. We were glutes and core and all the things, and having to do that. So doing, getting into that, and then having met you several years ago, and we've talked a number of times about that. Let's talk a little bit about the pelvic core, and probably blow some minds on how involved that is, and what you can do even in an orthopedic practice of things.
My favorite saying in terms of what is the core, the pelvic core, and how does the pelvic floor relate is the section on women's health of the American Physical Therapy Association at CSM, gosh, probably 10 or 11 years ago, was handing out at their table in the, what's that called? The big breakout.
Oh, what is it called? But it's
when you go in the big room with all the vendors and everything. Oh my God.
It's like the trade show, but that's not the word either. But
anyway, they had a table there and they were handing out magnets, and it said the pelvic floor. It's the floor of your core, literally. And I love that I think we often think of the core as the abdominal muscles. Occasionally you'll hear someone talk about the core as the back muscles. And in my opinion, the real core is, and you can argue that it's all the way from the vocal cords to the pelvic floor. And I think that's true. I think it's focused mostly on the diaphragm to the pelvic floor, and thinking about the core as a six-sided box. And I began doing Pilates after I was treated for a back issue. I had been doing power yoga and hot vinyasa for 7 years and thought I had a strong core. And my physical therapist who was treating me said, your core is crap. So, and I began taking Pilates, and it's when they first referred to the core as a six-sided box. And I loved that idea. So you think of the core as a six-sided box, with the top is the diaphragm, the bottom is the pelvic floor, the front is the abdomen, the back is your back muscles, and the sides include part of your transverse abdominis, your oblique muscles, internal and external, and your quadratus lumborum. And you think of that as a six-sided box, and using the breath to engage all of that. So with an inhale through the nose and then an exhale through pursed lips, imagining that all of those sides are gently coming together at a center point and drawing in through the ribs, the diaphragm, all of that musculature, and then the pelvis itself, everything kind of drawing in and up. So you cue the pelvic floor as well as those back muscles, those deep abdominal muscles, everything coming together to kind of create a lock for the spine and the pelvis and the hips to work from. So the core, you include that pelvic floor as part of it, and using an exhalation and verbal cueing to draw the ribs down and in, the belly to flatten, the waist to cinch, the pelvic floor to come in and up. And getting all of those components working is a really good way to practice training the core versus draw in your belly button to your spine. It was the traditional way that I learned in school. So thinking about all of those components as the core. And then when we talk about the pelvic core, we take it a step even further, is incorporating the hips into there. So you've got your hip muscles, your glute muscles, glute med, glute max, the rotator muscles of the hips with I always call them the Gemelli brothers, gemellus inferior, superior, quadratus femoris, your piriformis. And I know there's another little guy in there I always forget. And then your hip flexors, and all of those muscles supporting and functioning from how well the whole pelvic core is working, because they attach to the pelvis. And what attaches to the pelvis? The pelvic floor. What else attaches to the pelvis? The back muscles, the abdominal muscles. So all of these things that attach to the pelvis, thinking about them as sort of this unit that we need to train on a comprehensive level to be able to get to the core of the issue, but also the core of whatever it is that they're struggling with. Typically, you're going to find that that pelvic core is dysfunctional in some way or another. And thinking about all of those muscles as a unit to be able to return adequate movement with good range, appropriate range, and function, and mitigating pain. Yes, of course we want to eliminate pain, but I think it's unfair to say that we need to always eliminate pain, because pain is sometimes an indicator that something's going on, and sometimes we've got chronic pain issues that kind of snag up and flare up. And I think that sometimes if we talk about eliminating pain, when we talk about that, we've got a fringe level of individuals who think that any pain is bad, and that can cause acute on chronic pain cycles and pain panic and things like that, that people are afraid to have any pain. So just mitigating pain, helping that person become more functional, reducing their suffering that they experience as a result of whatever's going on physically, and how that impacts their emotions, and how their emotions impact their physical experience. It goes on and on. But getting back to the pelvic core, thinking about that group of muscles that work together in order to promote healthy, relatively pain-free movement.
Oh yeah, we could do a whole nother conversation about pain and
all
the things that we talk about, and that it is not black and white, that you have it or you don't have it. We could go all day about that.
Oh yes.
But I think we've done a good coverage of maybe opening the door that the pelvic core is a box, and there are parts of it that you can that need to be utilized, and you're going to get much better results. You're going to get much better results for yourself if you start moving around and trying to activate the pelvic floor, or relax it, per what's going on. So kind of if I'm sitting there going, okay, this is super interesting, but I want to know more, where would you direct somebody to learn more about getting into pelvic health in their career? And where would you direct somebody to learn more about the pelvic core, and if they were going to use that more in their orthopedic practice as they're coming into the profession?
For the individual, the clinician, the physical therapist, the physical therapy assistant who's interested in pursuing pelvic floor treatment and dysfunction as a career path, two resources are come to mind. I trained through the Herman and Wallace Pelvic Rehabilitation Institute and took their pelvic floor series. As a physical therapy assistant, you are able to do that. Even as a physical therapy assistant student, you can take the level 1 course and then pursue it further. The section on women's health through the American Physical Therapy Association, they also have an excellent pelvic floor series. I did not take that series. When I was graduating, I had better access to Herman and Wallace because they had courses in my region, and the section on women's health didn't. They've both expanded, and almost every state you can get training in now. I had to travel oftentimes to California from Michigan to get some of my training. But the section on women's health through the American Physical Therapy Association is also a great resource for continuing education courses for the pelvic floor series. For those who are curious and interested in learning more about the pelvic core, I have uploaded some YouTube videos that you can utilize and how to do an external pelvic floor assessment without touching anything for yourself, for your patients, and how to incorporate some of that into the treatment. You can just search Pilates based things too that often will incorporate that 6-sided box with breathing and how to train the deep core, that 6-sided box with the pelvic floor incorporated. And then, gosh, I don't know. Do you have any other resources that I'm missing?
No, not really. That's really where I wanted you to go with the two, because there's two camps if you're going into the pelvic health world, Herman and Wallace and the section of women's health. They may be an academy. I don't know if they switched.
Oh, yes. I'm sorry. They have changed. Oh my gosh. I'm so bad. It's, the Academy of Pelvic Health, I think now. It changed like over a year ago, and I just...
Yeah, the big change that came in APTA in 2020 into 2021 is most of the sections became academies.
Yes, you are correct. Thank you.
So as we are changing our terminology, so you can look there on the APTA website, and you do have a lot of good resources and more explanation about the pelvic core, along with, if you want to go more of that Pilates based visuals, education, verbiage, technique, different things like that. It's not Pilates and yoga are not just separate forms of movement. You can incorporate them into your therapy practice. There's yoga things that I bring into that. We've Americanized those two forms of movement, and to where people think you've got to wear yoga pants and twist yourself into a pretzel, or get on a reformer and do all these crazy things, and that's not at all the foundation of either two of those practices. So getting into more training, or even just videos and conversations about that, can really help your orthopedic treatment of men and women. And whether we're talking about just general orthopedics or into athletics, anything like that.
Yeah, we didn't even talk about athletes, which is a whole other area that pelvic floor dysfunction overlaps with orthopedic and neurological issues and injuries. So
yes, yeah, you and I could record for days between.
Yes, we could.
All the different things. Oh, well, Nicole, thank you for having a conversation.
Thank you for having me. I hope it's been insightful and beneficial for your students. I hope that it is eye-opening and not scaring them away too much from pelvic health.
Yeah, no, I think it was a great introduction, and moving through kind of the things that we wanted to touch on today. What it is, how can I incorporate that into my practice if I'm interested in that, and why it's important to be able to refer if I'm not interested in that, and why it's important to not ignore and put into our orthopedic practice, because as we talk all the time, we need to do better in our profession of treating people as a whole, looking at the whole picture and not looking at just what the dysfunction is.
Yes.
So
absolutely.
Okay, thank you for your time.
Thank you so much. Have a wonderful day.
Okay, you too.
Bye.
Bye.